gives you actually 1 extra credit point. Make sense? So instead of 6 and 6, I have this one that you'll get back today, 5. The other one worth 8. So kind of it would have been 5 and 7, but then I'm giving you like an extra, right? An extra point. Those I still have to grade. And I'm looking at handing back, and I know you saw the big vitals thing with those big graphs. That I made out of like, I don't know, it's like 36 points or something. Those I totally have to go through. But I'm aiming for next week to get all that stuff back to you guys. So let's at least get the reflex one back. Again, it's out of 5, right? Okay, Tiana and Elena and Eric. And Sharon. And Simon and Kristen. There are like 2 names on there. Let's see, Chandra. Denise and Casey and Morgan. You're welcome. Elaj and Jocelyn and Jen, Spice. Here's yours. And ooh, hang on to it till later. Rachel, Helen. Well, maybe we'll wait till the break. Rachel. Done. David. Oops. Oh my gosh. Georgina, Michael. Donna. And Heidi. Nicole. And Dina. Getting there. Let's see. This is here. No. Here. All right.
That's why I remember.
Getting there. Woo! Oh. Wow. No. Oh my goodness. Let's see what we have. We gotta scroll down. Let's see. We are officially, I don't know, is it officially? Wait, I don't know, maybe not officially, right? We're almost at, as far as number of weeks are concerned, we're almost at the halfway mark. We're at week number 7. Okay, oh my gosh. So we took that exam, right? Woo! Another one down. We are going to begin today our conversation about the heart. This particular PowerPoint is like one massive PowerPoint. It's like forever. There are a zillion slides in it. It's all of chapter 12, and I did not break up that chapter. Like I think there was one chapter, I think it was like 3 or something, where I broke it up into a couple of little separate, I think they were prezzies actually at that time. But this one I kept all together because the overlap in the cardiovascular system is, well, I don't know, I guess it's obvious, or hopefully it will be obvious. So I decided to keep it all together. However, I will chop up the exams. on this chapter. So instead of one like big scary exam on this big scary chapter, we are going to first have an exam 1 week from today on just the heart material, right? And we'll spend this week on the heart stuff. And then a week after that, we'll focus on the stuff that we're going to talk about next week, which is blood vessels and basically blood pressure. We're going to throw in a couple of labs in there. So we'll have that, and then we'll have the last exam on this little section, also separate on specifically the blood and the clotting information. Good? So we've got one giant chapter in one giant PowerPoint. I've got blocked out, let's see, 2.5 weeks to get through it, and we're going to take 3 separate exams, right? 3 separate exams. There's still going to be the 10 questions in the 10 minutes, but 3 separate exams. So I'll sort of tell you, this is where we're going to, right? Like have this next exam, and we'll, make an imaginary line there, and then, right? I'll warn you ahead of time. So that is what we're looking at for the this week, next week, and then into the last week of October. Good? All right. This is a rough section. We're pulling together, first of all, stuff that we already know in the nervous system, especially autonomic stuff. We're also pulling together stuff that we already know about muscle, of course, especially cardiac muscle. We're going to build a lot on the little intro that we did to cardiac muscle. And then we're going to add a whole bunch of new stuff for specifically blood. There is, in this section, kind of a lot of physics, actually, that we have to deal with. And specifically, we're going to be looking at pressure and the pressure that fluids exert on especially tubes, right, blood vessels, but also in that heart. So there's a whole new layer, right, that we're going to be adding onto this. So I'll just warn you ahead of time, this is a tough section. Even though I'm chopping up the information as far as exams are concerned into 3 exams, be absolutely sure, right, you've got a whole week to learn this heart. Be absolutely sure that you're hitting this stuff every single day, right, for this chapter. I'm just telling you, right? All right, so that's what we're looking at. This ECG lab, I already announced it, but just to confirm, we're going to, instead of doing this on Thursday, we're going to push that to Tuesday. Good? So this lab will happen a week from today. All right. Good. Let's see. So, oh, my goodness. Here's this. Here we go. This should be a review from anatomy, our little distribution picture of the overall basic components of blood. If you were to draw someone's blood and put that in a test tube, and then put the test tube in a centrifuge, which would spin the sample around and around and push the heavy stuff to the bottom of the test tube and allow the lighter stuff to float to the top. You would end up with this sort of separating out of the blood. So again, this should be a review from anatomy, but let's review it because we're going to be talking a lot about this in this chapter. This is really, really going to show up more in that end section on blood, but let's take a look because we do mention some of these numbers when we talk about the heart. So our separation is red blood cells are the heaviest, and plasma, which is the fluid part, is the lightest, and then in between we have a little thin section of white blood cells. And this would be our distribution out of 100%, right? So we've got about 45% in any given sample should be, if you want to be within normal limits, right, that WNL that we've been introduced to in lab, you should be somewhere around 45%, plus or minus a couple of points there. That leaves us with 55 plasma and about 1% little bit less than 1% on white blood cells. So, this number, 45%, when you go out into the world, if you have not already, a lot of people have, right, either worked in a hospital or volunteered in a hospital, the word that we would use to describe this percentage of the sample that is made up of red blood cells is hematocrit. So that's a word that you want to know. If you don't know that word already, hematocrit. 45%. This number is kind of taking into account males and females, plus or minus, right? Males are going to be different, actually, from females. Which brings us to this set of numbers over here that I put up here. We'll look at this one in more detail when we get to blood. But let's look at this set of numbers over here. The blood volume, the entire blood volume in a human being, right? So not a sample anymore, but all the blood that's in you right now. For the average person, and we know we've been introduced to this idea way in the beginning. Average person, they're going to count in our textbook, and in most textbooks they do the same thing, 70 kilo person. And they're also thinking kind of on the younger side of adulthood and average condition, right? Like physical condition and no big major disease processes underlying. So you're kind of average person, about 5.5 liters floating around like right now, right? We can break that down into males and females. The males will be on the higher side, right, of that 5.5, and the females are going to be on the lower side of that 5.5. And those numbers that you see there are all considered to be within normal limits for total blood volume. Again, average person and all that stuff. All right, so you definitely want to know these numbers, not only for this exam or set of exams coming up and also final exam, but it's good to have them in our heads ready because they're going to pop up as we talk. So you want to have them easily available in your head. This should definitely be anatomy review, right? We've got heart in the center, and then we've got our pulmonary circulation and our systemic circulation. So be sure that you've got all of your anatomy up front also. This particular table, you do not have to know the details of this table, but this is to give you an idea of how much blood is flowing through these particular major organs that they've picked out over the course of a minute at rest. Again, average person at rest. But this is just, I kept this in here, even though you don't have to memorize it, just to give you an idea of, you know, what perhaps at rest our priorities are as far as blood flow is concerned. Because, of course, blood flow, then you can take that to the next level is oxygen delivery, right? And, of course, with that glucose delivery. So this gives you kind of a sense of at rest, what are the body's priorities? Good? All right. So we've got some definitions, some terms, right, to know right up front, and you definitely want to know these terms and their abbreviations because we are going to use them over and over and over again for this chapter and the rest of the course. So the title of this slide is Hemodynamics, hemo for blood, and dynamics is sort of movement and doing stuff, right? Maybe a combination of those ideas. So we've got some relationships between these three items that we're going to define. Blood flow, blood pressure, and resistance to that blood flow. So let's see, we've got blood flow, and whenever we see in graphs or in a mathematical equation for the rest of this course, right, we're going to use capital F, right, as our abbreviation. So whenever you see the capital F, we're going to think blood flow, right, blood flow. All right, so, I mean, blood flow, movement of blood, that's sensible, right? Very, very sensible. And let's realize that that movement is always going to occur from an area of higher pressure to an area of lower pressure. We've already talked many, many times about concentration, right? And items moving from an area of higher concentration to lower concentration, right? So we're going to take that same idea, switch over to a little bit of physics, right? And I know a lot of people have not yet done any physics, but we're just going to mention like the super basics of physics that we need to get through this conversation. So when we're talking about liquids, fluids, right? Because that's what blood is in a container, which is the heart is a container and our blood vessels are containers. So when we're talking about fluids in containers, they're going to, well, let's do pressure after. But they're going to, first of all, they can flow, right? If there's maybe an entrance and an exit to the container, so we can have movement. But that fluid, whatever fluid is in the container, can also sort of push, right, against the confines of that container, right? So depending on how much that fluid is pressing on the outside, that would give us pressure. Actually, that's our next word, blood pressure. So it's that force that the fluid is pushing on its container. So if we've got an area where that force is greater, and then maybe next to it we've got an area where that force is lesser for some reason, right? We've got a differential. So that fluid is going to want to move, right, from the area of higher pressure to the area of lower pressure. So that's how we generate flow, is by sort of creating different pressures in different locations. Blood flow, we're going to measure in liters per minute. Blood pressure, we're going to measure in millimeters of Hg. Chemistry, what is that? Mercury. Ooh, that's good. Mercury. All right, there wasn't even a pause there. Excellent. So, the reason why we use mercury is because a long time ago, originally blood pressure was measured according to how high in a tube you could push. They would put mercury in a tube. Like, you know the old-fashioned thermometers with the red, right? Yeah, so that's what it was. So originally you would measure how high could you push that mercury in a tube. And it was a distance, so it was millimeters of mercury. So they've kept that unit of measurement. Okay, great. And now we've got our final word, resistance. We're going to abbreviate that as a capital R. And resistance, I mean, we've talked a little bit about resistance when we talked about electricity, right? And resistance for electricity was, you know, how difficult or easy it was for that electricity to travel, right, to move. So it's kind of the same thing, except instead of talking about electricity, we're talking about fluid flowing through its container. So resistance is how difficult that is, right, for that blood to flow through the container. All right, let's see. Oops. Here we go. So, all right. So here we've got an example of two tubes, and these, the intention is to have these tubes be identical, specifically their diameters, right, are identical, so that makes them the same size. And we're going to have fluid flowing through the two tubes. Great. And they're telling us P1 and P2, that's standing for pressures, whatever pressures, and they're giving us two different situations. They're giving us this situation where pressure number 1 at this point is 100 millimeters of mercury, and pressure number 2 at this point is 10. So we've got an area of greater pressure to lesser pressure, and that gives us a difference or differential, right, of 90. Okay, great. So we expect the fluid to flow from here to here, right? I mean, that should totally make sense. Great. Let's look over here before we talk about the flow rate. But let's look over here. They're giving us a different situation here. They're saying pressure number 1 is 500 and pressure number 2 is 410. But our differential is the same, right? Difference of 90. So first of all, we're going to expect the same thing, a flow from high pressure to low pressure. And now they're giving us the rate of the flow, right? Like how fast did that happen? And they happen to measure in these two different situations, and they're telling us, oh, the rate is actually the same, right? rate is actually the same. They're telling us in this example 10 milliliters. They switched it from liters to milliliters, which is totally fine. 10 milliliters per minute. And then down here, 10 milliliters per minute. So it didn't matter that these two pressures were significantly lower than these two pressures. What mattered was that the difference was the same, right? And then we had similar or the identical flow rates. Good? So we're going to keep that idea in our heads. We're going to also keep in our heads what I wrote at the top. It got cut off, but I think you guys can see it better than I can. This mathematical idea that the flow rate is going to be directly proportional to that pressure difference. So we have to switch a little bit into math. So that statement, hang on to, we're going to talk about it a little bit more. All right, so just hang on to that for a second. Here we're going to have a different example, and they're giving us a different picture. And in this textbook, they use this setup a lot to talk about fluids and the physics of fluids, where they have these tubes, right, and different size tubes. So we're going to get used to this type of drawing, right, this type of setup. So at the top, first they're giving us this tube, which has a particular radius, and then this tube, which has a radius that's half of that, right? So we would expect fluid to flow more easily and quickly through this one, right, than this one. I mean, we should know that already. So let's take that little piece of knowledge and let's apply it to more of a situation. So here we've got one tube that at the bottom splits into two tubes. And the one tube is this one, right? And the other tube is this one. Good? So we would expect, because of what we know from the top, we would expect the fluid to flow more quickly through this one than it does through this one. Good? Very sensible. This is all very sensible. We have a terrible bunch of math down here. We are not going to worry about the details of the terrible math, right? We will have a little bit later today some relatively much simpler math that we are going to worry about, but this one, no. We're not going to worry about the details of ugly math. I call it ugly math, right? But I will warn you, the ones that we're going to worry about. This one, no. But the idea that we can take away from this is this statement under here, that this flow is inversely proportional to resistance. So the previous slide was saying, right, in words, using that word proportional, directly proportional, and now this sentence is using the words inversely proportional. So if we do remember back to a little bit of math, right, proportional and directly proportional and indirectly, right, proportional. That kind of had to do with where in the fraction it was, right? Like if both things were at the top of the fraction, or if one was at the top and one was like the denominator. Remember? Oh, that's math stuff. So this inverse relationship is when something is in, like on the other side of that equation is in the denominator, right? So we at least can remember that. All right, so but don't worry about the details. But we can worry about that statement and maybe the using pictures, like what that means to us practically, right, instead of mathematically. Make sense? All right. So if we have this situation where we've got a smaller radius, do we have higher resistance or lower resistance? So smaller radius, higher resistance, right? So if we have a higher resistance, what about the flow? Slower, right? Right? Slower, or you could say lower, right, or slower flow. So do you see how that works? And that's an inverse relationship. So we'll kind of get this instead of mathematically. We'll get it on a conceptual level. All right. Very good. This should be a review, just listing all of the parts of the circulatory system and basically what each part is responsible for. So just go ahead and review that. Be sure you remember all the parts. Also, be sure that, I think we skipped one by accident, yes. Be sure that you remember all of your heart anatomy, and here they're giving us the arrow showing the direction of flow of blood through the heart. You must remember that. Let's see. Be sure you remember all your information about the 4 valves of the heart. And here's just in kind of a table format, that direction of flow. I think this goes, through the entire system. Be sure that you know that. And now we come to this. This should be quite a bit of review. And now we're going to add some details for physiology. So we've got our innervation of the heart. Because it's cardiac muscle tissue, this is all under autonomic control. And of course, autonomic is parasympathetic and sympathetic. We know all that stuff, right? Parasympathetic travels through vagus nerve, right? Which is cranial nerve number. Woo! No hesitation. Love that. And then sympathetic, remember there are no cranial nerves, right, involved in sympathetic system. You could also say there's no sympathetic component in any of the cranial nerves. But our sympathetic information is going to travel through spinal nerves, and specifically thoracic spinal nerves. Okay, pretty good. I mean, that makes sense because heart is in the thorax, right? So that should totally make sense. Excellent so far. Let's go over here. We know from our favorite table, the scary one, right? The scary one. That in the parasympathetic system, we're always going to be using acetylcholine, right? And, our receptors on the target organs. Right? What does M stand for? Woo! No hesitation. Love that. Awesome. So, awesome, right? This is all just confirming what we already know. Woo! Excellent. Let's see what else we got. And then over here, sympathetic. We know that in the sympathetic neurons, we're going to be releasing norepinephrine. We've got that, right? And approaching the heart from the bloodstream, right? A little bit of a backdoor action. We're going to have mostly epinephrine. We'll have, just to say it, we will have a little bit of epinephrine come out of the neurons, and we will have a little bit of norepinephrine approach from the bloodstream. But it's mostly norepinephrine coming out of the nerves. It's mostly epinephrine coming out of the bloodstream. So we're just going to keep it simple like that. All right. Anyway, woo! Norepinephrine exiting, right, or being released from these sympathetic neurons, and epinephrine approaching this heart from the bloodstream. Where did that epinephrine come from? What organ that dumped the epinephrine into the bloodstream? Woo! Adrenal medulla. Woo! Awesome. Very good. That's re-anatomy review. So anyway, look at all of these pieces, right, of norepinephrine and epinephrine floating around, and they are going to be received by these receptors. Remember, for sympathetic stuff, norepinephrine and epinephrine, we would have adrenergic receptors, and our choices were alpha and beta, right? And we're not going to worry about alpha 1, alpha 2, beta 1, beta 2. We're just going to say alpha and beta. That's good enough for us. So here on the heart muscle, we're going to choose the beta receptors, right? Of the adrenergic receptors, we choose the beta ones, not the alpha ones. We'll use those elsewhere, right? But for here on cardiac muscle, we're going to choose beta receptors. Awesome. And those are the ones that are going to accept or bind, right, the norepinephrine and the epinephrine both. Good. So both of these items will fit onto all of these beta receptors. So far, so good. They've added for us here this box representing the atria and this box representing the ventricles. Let's just take a little note at, we seem to have the beta receptors on both the atria and the ventricles, and we seem to have muscarinic receptors just on the atria. All right, that's okay. Maybe this will play into something as we keep talking. All right, So clearly, this picture is a big deal, right? As far as memorizing. Good? But it's a lot of stuff that we already know. All right, very good. Very good. Let's start our discussion focusing on the heart with this conduction system. A lot of this should be anatomy review, conduction system of the heart, but now we're going to talk details. All right, so far, we should know that the conducting system of the heart is still made up of cardiac muscle cells, right? Cardiac muscle cells. Even though in this picture of the heart, and a lot of textbooks kind of do this, which I don't know, I wish they wouldn't, but even though in this textbook we see in yellow, that's the conduction system of the heart. In most textbooks, we've already seen in the nervous system, right? They usually make the neurons yellow. Like especially in anatomy, when we would see arteries, veins, and then neurons, and the arteries would be red, and the veins would be blue, and the neurons would be yellow, right? That's kind of a standard, traditional type of way of color coding those three items. Here, do not get confused. Do not get confused between this yellow, representing the conduction system of the heart, and the yellow that is always neurons, right? These items are not neurons. These items are still cardiac muscle cells. They are cardiac muscle cells that have decided to, let's say, subspecialize, right? So they're still cardiac muscle cells, but they have decided to commit themselves to being part of this conduction system. Because they've made that commitment, they're going to have a super special job, but what they've given up for their super special job that we're going to talk about, what they've given up is that ability to contract. I mean, we know, right, that cardiac muscle is going to contract. We saw that in the previous chapter, our little intro to how the cardiac muscles contract, right? So these particular cells all lined up in order in different locations, and unfortunately yellow. Like I wish they would have made them green or something, right? Because then we would know for sure they're not neurons. But we're stuck with the yellow. So I wanted to be very, very clear that these are not the same as neurons. They're cardiac muscle cells that have subspecialized and made a commitment to, okay, they're going to do electrical stuff, kind of like neurons, but they're not neurons. Good? And by making the commitment to be electrical, right, they've sacrificed their ability to contract. All right, all the muscles around them, all the cardiac muscle around, yeah, they'll contract, but not these guys. Good? So Chandra, did you have something, or did that?
Yeah, that answer. I didn't know if they were conducting cells or cardiac muscle cells.
So they are cardiac muscle cells,
Okay.
but they're like a subset
Okay.
of cardiac muscle cells, right? So like let's say, like when I say subspecialized, let's say you have like a pediatrician who takes care of kids, and then you might have the cardiac pediatrician who specifically deals with kids, but just focuses on heart problems for kids, right?
Yeah.
That would be like a subspecialty.
Okay.
So this kind of idea, yeah, heart, but you know we're just going to focus on conducting electricity in the heart. We're not going to do all the other stuff like contracting.
So the cardiac muscle cells everywhere else, but in the conduction system can contract.
Exactly. Exactly. All right. So far, so good. Let's see. I wrote another little bit of information that has to do with that. These conducting cells have, the way that they're built, they have a low resistance to electricity. So we're stepping away from flow just temporarily and focusing on electricity. But low resistance to the movement of electricity, which allows action potentials. We know in muscle, action potentials are different, right, from in nerves, but we know what they are. We're gonna see it again. Action potentials to travel quickly, which is going to be important if you want the heart to contract quickly and then relax quickly. Good? It's one of the things. All right, so be sure that you know cold, right? These components of this conduction system, which is anatomy review. Good? All right, let's see. Let's see. Here we go. So, the conduction system is going to, let's say, fire, right, or generate action potentials. And remember, they're going to be more muscle action potentials, not neuron action potentials. We did see in the last chapter there's a slight difference there. So we're going to generate these action potentials in these conduction cells in order, right? In a very, very specific order to get the heart to contract, the rest of the cardiac muscle cells to contract in a very specific order, right? So they're just showing us here the order, the sequence, right? By kind of highlighting, again in yellow, highlighting what's happening when. So we're going to start at the SA node, right? You see that kind of flash of yellow up here. And then we've got some arrows traveling, right? Sort of out from the SA node. And now we've got both atria, right? Firing. And we're aiming for that AV node. And it's at the AV node because of its shape and orientation. See how it's kind of, it's sort of like sideways, right? So because of that, the AV node actually, instead of firing right away and sending the signal, it actually delays the transmission of that, or those, I should say, action potentials for about a tenth of a second, right? So we're going to hold up for about a tenth of a second. We're going to allow the ventricles to fill just a little bit longer before, and we'll talk about that a little bit later, before we go ahead and allow that signal to continue through our bundle of His and then down our bundle branches, right, in that interventricular septum, down to the apex, and then along these Purkinje fibers, and then we get those ventricles to contract. And then we're quiet. And then we're going to start over. Good? So that's our sequence. Down here, we see an ECG tracing. This is just an intro. We're going to save a little bit more detail for ECG stuff for a little bit later, and then we'll actually pull out the machines next week, right? And we'll actually do some stuff on the ECG machines. But this is just an intro so that you can see that or get this idea that these electrical events in the heart will sort of, and I emphasize sort of, and I'll explain why later, sort of can be graphed, right, on this piece of paper, right, called an electrocardiogram, or it could be just the screen. And what they would sort of correspond to would be, there's a little blip, and that happens to correspond to this moment where the atria are contracting. And then we've got, oh no, go to here, this kind of big blip, right, that has a particular shape to it. And that sort of corresponds to ventricular contraction. And then we've got our quiet time, right, our quiet time. And that's going to correspond to this final blip over here. Again, we'll talk about all the details of the blips in a little bit, right? We're going to save that. And I'm also going to save, why do I keep saying sort of, right? Sort of corresponds. I'm going to save that for a second. But let's just realize we can start to maybe tie the two together a little bit. All right. So we'll see. Keep that off to the side. All right. Oops. There we go. So, this should look familiar, right, from the exam that we just took, right, on muscle tissue, muscle physiology, and we did spend most of our time on skeletal muscle, but we did look a little bit, right, at cardiac dilatation, contraction, coupling, right? Like, what was all this stuff that happens, and then we couple that to the contraction stuff, which, it ended up being the same, right? The cross bridges and all of that, and the ATP and all that stuff over here. That was basically the same. All right. So the details, right? All this stuff, this is all the same as what we already know. So I'm not going to go over those again. But let's think about some of the things that were different in cardiac muscle compared to skeletal muscle. Specifically, there was some calcium stuff, right? Those things were quite different, and we should talk more, right, about why would you do that, right? Why would you build a whole different thing in a different muscle tissue? Like, if you're going to build something differently, you better have a good reason, right? And the reason is because we want the heart muscle to function differently from skeletal muscle. Let's think first before we go over all the details. Skeletal muscle, we want to move, right? We want to walk or pick something up or something like that. So for skeletal muscle, all we want is for the brain to tell the muscle contract, right? Because I want to pick up this thing. So I'm going to tell bicep contract, right? That's all I really want in that skeletal muscle. Good? All right. And then, whenever I'm going to release that, okay, I can do that. Okay, fine. Blah, blah, blah. But for the heart, it's not that, right? We don't tell the heart contract, right? Contract. We would be able to do nothing else, right? Contract. That's boring, right? Plus, what do you do when you're asleep? Okay. So, okay, let's let autonomic system take over. Okay, so that's pretty good. So we get that. Okay, within that idea, autonomic nervous system take over for us. Great, we don't have to think about it. Awesome. All right, within that, okay, we've got the heart beating, but like, would we ever want the heart to beat and then stay like that? No, of course not, right? Because then you wouldn't be filling, right? That's no good either, because then you wouldn't pump. Okay, that's no good, right? So, unlike skeletal muscle, where if I wanted to hold this for a long time, I'm going to keep telling this muscle, keep contracting, keep contracting, keep contracting, and I'm going to generate, remember, tetanus, right? Okay, we don't want tetanus in the heart muscle, right? Because then we would be like this, and we would never feel the heart. Bad situation. Okay, so the way to do that, but still keep a lot of this stuff, right, is to just make a couple of little adjustments, which we already know, right? We add, or we kind of make a little adjustment here, right? This calcium channel. Remember, we were just going to let in a little trigger amount of calcium at first, and then that was going to trigger this calcium channel to open, and then the rest was kind of same, right? And then we can pump all that calcium after the contraction. We can pump it back in to sarcoplasmic reticulum, right? So that was kind of the same-ish, but we did have this extra step, right? Okay, first we had that, and then we added in, right? We added in this additional calcium ATPase pump in the sarcolemma, right? So not only this one to, let's get rid of that calcium, right? Also, we've got like an extra one over here. You know what? Let's get rid of that calcium faster. Make sense? So, we already know what happens when you get rid of the calcium in the cytoplasm. What can you do when you get rid of the calcium? Relax, right? So, we see, first of all, we're going to work backwards. We see, first of all, that the cardiac muscle can relax faster, right? Because we've got an extra pump, an extra calcium pump to do that for us. First thing that makes sense, I hope? right? So we can relax faster. That is super important, right? Relax faster. Relax faster, right? Instead of, whatever, right? Okay, so that's the first thing. Also, we've got something about this, right? This particular calcium channel that was in charge of the trigger amount, right? So now we're talking about that contraction in the first place, right? Starting the contraction in the first place. It turns out that this particular channel is built in such a way that it actually stays open. It's going to let in a little bit of calcium to trigger this one, but instead of like closing right away, it's going to hang out in that open position. Okay, all this other stuff is going to happen, right? But this is going to stay open for quite some time. In fact, until this whole thing is done, right? And then it'll finally close, and then it's ready to start over, right? For the next contraction. But until then, it's going to stay open so that, just in case a second impulse arrived, right? Let's say a second burst of norepinephrine arrived while this was still open, right? Well, too bad, right? Can't do anything. Remember when we talked in the nervous system about absolute refractory periods, and no matter what you did, if you were in a certain area, right, the peak of that action potential for a neuron, as long as you were under that area, we had sodium channels like wide open, and well, they're open. There's nothing you can do, right? And we call that absolute refractory period. Tough luck, right? You gotta wait that one out, right? So it's the same idea here, but instead of in a neuron, we're in a cardiac muscle cell. So as long as this channel is open, it's open. You can't open something that's open, right? So you can't generate another cardiac muscle action potential. Good? You have to wait it out. And then the next, okay, you wait till the next one. Good? All right. So that's important because if we've got a contraction going, you don't want the heart to generate another action potential and turn that into tetanus. Right? Good? Makes sense? All right. Very good. Let's see. Here we go. Here's our tracing of that cardiac muscle action potential. So we already know what neuron action potential looks like, right? That was and then, right? That one. We know what skeletal muscle action potential looks like. It was pretty close, actually, to a neuron action potential. Maybe a little bit shorter on that end part, but it was kind of close. So here we've got what it would look like for, specifically this one is a ventricular cardiac muscle cell action potential. So it's kind of different, right? Some things are similar, but there's some things, right, that are different. Let's see what's different. Let's look at our resting membrane potential about -90. All right, so we should know that. Wow, that's pretty steep. And then, right, we have all of our things entering and exiting that we already know, right? You can review from that previous thing. This seems like it's sort of slow. And then we've got a sharp drop. So far, so good? All right, but we can tie this together with that previous slide and all the movements of all the items. All right, so far, so good. Let's see. Here we've got a tracing of what an action potential would look like specifically in the SA node, so it's different. So different parts of the heart will have different looking action potentials. SA node, right? SA node. First of all, let's see. Resting potential is pretty close to 50. We've got threshold a little bit above that, and this shape we could say is rather similar to something that we've seen before. We know SA node is our pacemaker, right? For our whole entire heart. We talked about in the last chapter, remember pacemaker potentials? Okay, so we could, if we were to, let's say, stretch these out, right, sort of stretch them out this way, you see how those could be rather similar to the one that we just saw, right, in the SA node. Let's go back to that. See that? That's like that top graph, maybe a little bit, you stretch it out, right? And then we've got our SA node potential. What was the thing about pacemaker potentials that, like, we already know? I don't know. We already know some stuff. Yeah, leaking, ions. Yeah, I'm gonna focus on this one. Just a little more in digestive, but let's focus on this one because this is much closer to the SA node situation. Leaking ions, and then it was like, well, the moment that you hit threshold, right, and then you come back down. Leaking ions, the moment you hit threshold, right, that, right, that idea. So we have a word for that. It's called automaticity. Automaticity. It's the capability of a particular cell, in this case, those SA node cells, right, to do that. And it's spontaneous, right? It's spontaneous because of all those leaking ions and then hitting threshold and right? Okay, so it's spontaneous. It's rhythmic, meaning it has a cycle to it, right? And it does it by itself. So that's the self-excitation. Good, right? Okay. That's an important word, right? That's an important word. Okay, so this is how and why the SA node is a pacemaker. Because it can do this by itself. Awesome. If we were to take away all the innervation of that SA node, and the innervation is parasympathetic and sympathetic, right? If we were to take that away just for a moment, and let the SA node just go on its own. Just go ahead and do that, right? Over and over again on its own, right? It would generate about 100 of these depolarizations, right? 100 of these in a minute. That's pretty fast, right? What do we know? We talked about it, but also we did our vitals lab, right? And what do we know at rest? Because all of us are, pretty much young, on the younger end of things, and I'm assuming or guessing decent health and decent shape, right? For pretty much everybody in the room. So what, I don't know, what were most people's, if you can remember, resting heart rates? So you have 60, most of 60, probably 70s, right? Right, somewhere in there. Okay, so, I don't know, that's a lot less than 100, right? Oh. Well, it turns out, once we add on parasympathetic influence and sympathetic influence at rest, there's going to be a little bit more of parasympathetic influence than sympathetic influence, and that's going to pull that heart rate down, right? Down. So we're going to talk about that a little bit more. Good? But let's definitely know this number 100 is going to factor into a later discussion. So let's remember that number. Without any autonomic input, SA node on its own generates about 100 of these in a minute. All right, so we're going to keep that. Let's look over here. We know that the SA node is at the top, or the beginning of that conduction system in the heart. And then we've got the atrium, and then we've got AV node, right? And then we've got bundle of His, and then we have bundle branches, right? And then we have Purkinje fibers. Each of these lower, or you could think later, locations in the conduction system have their own inherent rates of generating depolarizations. As we go lower in the conduction system, we actually get slower, right? In our inherent ability, that's without autonomic influences, right? Inherent ability to generate these. So let's take a look. Let us also remember these numbers.
These numbers are not in this slide.
Oh, I was going through this yesterday, and I did add a couple of things in here, kind of based on, I don't know, what I really want to focus on for this semester. So if you ever see anything as I'm talking that is not in the slide that was originally uploaded before the class even started, because it's kind of like as we go, it's like, oh, I think I'd like them to know that. You know what I mean? Then just go ahead and like write it in, especially if I say, oh, we want to know that. So anyway, let's be sure that we have these numbers. AV node, only 40 to 60. That's a big drop, right? From 100 to 40 to 60. Bundle of His, and then continuing on to Purkinje fibers, we drop way down to 20. That's incredibly low, right? Okay. Let's, again, keep these numbers in our heads. We're going to apply that to a conversation that's coming up. All right. Does everybody have that? Because yeah, I did add those, the numbers.
On the slide, it's not.
Yeah, so not in the original slide that I uploaded like in August.
The last two sentences are.
But as I was kind of going through things yesterday, I was like, I think I want to add that in, you know, so you guys have it. I mean, I always talk about it, but then people have to write it down anyway, so I thought I should just type it in, right? All right. So anyway, let's see. Oops. All right. We're not going to go over the details of this picture because we're going to do that next week, right? But I did want you to at least have this picture in the lecture stuff, well, because we are going to do it in a lab, so you'd have it. This is just showing places where you can stick leads on for the ECG machines. And again, don't worry about the details. We'll look more at these in the lab. But you've got that. So far, so good. Let's see. So now let's talk a little bit, since we're still in the topic of electricity in the heart. Let's talk a little bit more about this ECG tracing. So we saw this before, right? When we looked at that picture, they were kind of highlighting in yellow the atria, the ventricles, right? All of that. So here now we're just looking at the tracing itself. So we've got voltage and we've got time. Voltage and time. And we see our initial blip, and we're going to put letters onto the blips, onto the points along all these little blips. And this is standard stuff. So we've got a little blip first, and that's a P, or a P wave, right? And then we've got our next blip. It seems to be this kind of jagged thing, right? And we're going to give each point to the jagged shape a letter. So we're going to go in order. Q, R, S. Q, R, S. The points, the 3 points of that jagged shape, and we'll call this the QRS complex. QRS complex. Fine, it's just a name. And then we've got our final blip. So it's, in this particular tracing, a little bit bigger than that blip. And let's continue with the lettering T, or T wave. All right, so we've got our 3 basic components of an ECG tracing. P wave, QRS complex, and T wave. So far, so good. Let's see. Remember when I said this ECG tracing, it's sort of a reflection of what's happening in the heart electrically? It turns out that this particular tracing is not a direct measure of exactly the voltages passing through cells, right, cardiac muscle cells. It turns out what it really is a tracing showing what's happening in the body fluids between two of the leads. What's happening in the body fluids is a reflection of what's happening in the heart. So it's, I don't want to say it's a matter of semantics because it's more than just language. It is something happening in the body. However, how can I say it? The what's happening in the body fluids is close enough to what's happening in the heart that in practice, we can use the ECG tracing to tell us, right? This is what's happening in the heart, right? But I just want you guys to know for sure that the tracing is not like directly, this is exactly what's happening in the heart muscles. The way that we were able to measure, remember we were able in neurons take a voltmeter and put those electrodes, right? And they do this maybe not in our class, but in somebody's PhD lab, right? We're working on neurons, and you can put that electrode right inside that neuron and measure that inside surface of the membrane, right? And we measured gradient potentials and action potentials. So here, we're not, right, for an ECG, thank goodness, right, because we're going to do this on ourselves next week. We're not taking electrodes and putting them into the heart, right, itself to measure exactly, this is exactly what's happening in these cells, right? No. We're just going to measure from the surface of the skin, right? Okay, that's safe, right? So we can measure what's happening on the surface, and we're actually measuring what's happening in the body fluids, but that is a reflection. If you've got two leads here and here, right, and the heart is in between those two leads, all that fluid that's in between here is reflecting what's happening. Because this is big, right? The amount of electricity that's being generated here is big enough to influence and to be sensed on the skin. Good? So it's a little bit of a subtle point, but I want you guys to know that, right? All right. Let's see. Wait, do I have... Oh, okay. Well, before we go to this one, just take this, right? And be sure that you remember how to match up, right? Having said all that stuff about this is not a direct measure of what happens in the heart. Having said all that, be sure that you can still match up what's happening during the P wave, right? Atrial contraction. What's happening during the QRS complex, ventricular contraction? What's happening during the T wave? Everything's repolarizing, right? And everything's relaxed. Good? All right, so that's what's happening. So be sure you can go back to that previous picture and match it up. Good. Now, let's look at this top drawing, which is an ECG tracing between two wrist leads. And this looks like, we don't have the markings along the bottom showing us time, but let's just assume that this is going to be your average person, right? 70 kilos, relatively young, and decent shape, right? At rest also. So let's just assume that, and let's say this is that person's tracing, ECG tracing. And let's also assume that this is somewhere in that 60, 70, right? Maybe no more than 80 beats per minute. Good? This. So we see in a very regular fashion, PQRST, little space, PQRST, little space, right? And each one of these whole entire things would be a heartbeat, right? A heartbeat, a heartbeat. So far, so good. Let's compare this with this. So assuming that this is normal, right? Let's compare that tracing with this tracing. This looks really different, right? Really different. What do we see? We see a P, whoops, nothing. And then we see a PQRST. I don't think that's okay. Oops, there's a P, whoops. My goodness, there's another P. Wow, there's a big space there. QRS, there's a P in the middle. How'd that get there? And a T. That does not look good. That does not look normal anyway, right? Sure enough. Let's see. I don't know. How could we possibly figure this thing out? right? Like, what is going on here? Huh. We can take stuff that we already know and figure this out. We already know the inherent rate of the SA node, which was what when you take away autonomic stuff? 100, right? 100 depolarizations per minute. And what about AV node? Yeah, something we dropped down to 40 to 60. And then we had the rest of the system. 20, exactly. So, let's see. We did say that the P wave was representing atrial contraction, right? And that happens right after the SA node fires, right? So we would expect P waves to occur, let's take away all the autonomic stuff, right? Just to keep it simple. We'll take away all the autonomic stuff so we can think about our pure numbers. And we would expect to see P waves occur at a rate of 100 times per minute, right? And we're going to have time down here, right? So we would expect to see 100 of these in a minute, P waves. Good? So far, so good. How often would we expect QRS waves if we took away, not only now we're going to take away some more stuff, if we took away autonomic stuff, that was 40 to 60, right? We already said that. What if we took away the SA node? Because since the SA node is the fastest one, that's the one that's going to show up the most. That's the one that's going to control all the others. But what if we took away the SA node for some reason? Took it away. What's next in line? The AV node, which had a rate of 40 to 60. So, what happens after the AV node? We're going to pause, and then we're going to let everything fly, right, through the rest of the system, and eventually get that ventricular contraction, right? And even when we get down to that bundle of His and bundle branches of Purkinje, whoops, then we drop down to 20, right? So let's say we're relying on the AV node, and that's next in line. So what are we expecting to happen? We should see something at a rate of 40 to 60, because that something is eventually going to be QRS complexes, right? Because once we release that trigger, right, that electrical stimulus from AV node, we're going to end up with a ventricular contraction. So we should look for QRS complexes, right? All right. So we would expect to see QRS complexes happening at a rate of only 40 to 60 per minute. Let's take that one step further. Let's say we take away AV node, the influence of AV node for whatever reason, right? And we're left with the rest, bundle of His Purkinje fibers. Okay, we're still looking for QRS complexes, right? Because we're still, that's still going to create that ventricular contraction, but now what's our rate? 20. Make sense so far? Okay, so what we've got happening here is we still see evidence of something happening in the atrium, right? So we've got the SA node firing. Okay, and we see the result of that is atrium contracting. But something happens along the way, something in the middle happens, and then we do still see our QRS complexes, so we still are having ventricular contractions, but look at what's happening. They're not happening in order, right? They're not happening every time the atria contract, oh, then the ventricles contract. So there's some kind of a blockage in the middle there. Some kind of a blockage that is not allowing everything to happen in sequence, right? So we see evidence of our atrial contraction, we see evidence of our ventricular contraction, but because there's a blockage, they're not going one to the next and then come back to the beginning. One to the next, come back to the beginning, right? We're getting this happening, this represents atria, and we're getting this happening. Right? You see that? Because there's, for some reason, some kind of blockage in Good. So these two are happening independently. And we see that on the tracing as P's, QRS, QRS, right? Let's say 20. And this is 100, right? You see it? So here we've got some sort of block. A lot of times it's going to be a bundle block. Right? And some people have heard of that. We've got different combinations of this in different patients for different reasons, which we won't go into here. But I just wanted to introduce this idea to you so that you can, by looking at something abnormal, understand better what's normal, right? What's normal. So this would be some kind of bundle block for some kind of reason. You could address this with maybe some kinds of medications, maybe even a pacemaker, right? And I think, if I remember correctly, I'm pretty sure that most of the people in anatomy were from Spring. Did we have the pacemaker? And I think Winter also.
Yeah.
Did we have the pacemaker cadaver?
It was left at
Okay.
spring.
I'm pretty sure I remember both semesters that cadaver had the pacemaker. Yeah. Okay. Good. Good. All right. So we see a situation where that could come in handy. All right. Super awesome. Physiology awesome. All right. You guys are laughing. All right. That's okay. Let's see. We're going to take a break, but this is our last slide before the break. Before we move into our break and into our next, oh my gosh, big section of ideas, let's sort of summarize and set ourselves up, right, for mechanical stuff. So far we've been focusing on, we had our little intro on fluids and pressure and flow, right? And then we focused on electricity, right, in the heart. And let's summarize stuff about electricity that is going to be really important for, after the break, our discussion on contraction, right, that physical contraction. All right, we talked about how you cannot generate another action potential, therefore another contraction, while a cardiac muscle cell is in the middle of contraction, right? Because of that absolute refractory period, so we reviewed that, and that had to do with those calcium pumps, right? And calcium channel in that cell membrane, right? Okay, and maybe we can add this additional little statement. Maybe we knew this, maybe not, but let's be sure. The amount of calcium in that cytosol, right, for that particular contraction is going to determine the strength of that contraction. So if we have one particular contraction that has kind of a regular amount of calcium released, using that whole mechanism, blah, 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 right, we'll get this strength of contraction. If, let's say, on the next contraction, we happen to, for some reason, dump more calcium into that cytosol, we'll have stronger contraction. Good? If, let's say, next contraction, for whatever reason, we dump a little bit less calcium into cytosol, we'll have a softer, weaker contraction. Make sense? All right, so we're going to take these ideas into our next whole section after our break, which is contracting. Good? So far, this was just electricity. Awesome. All right, let's take a break after all that. We'll make it like, I don't know, between 9:45